Welcome back. Hey, it is Saturday. I hope everyone had a fantastic holiday. I'm Earl Stephenson Jr., your Atlanta board certified plastic surgeon, and welcome to Plastic Surgery T&A. That's talk and advice, where you get all things plastic surgery, but most importantly, you get truth with your transformation. Again, I'm Earl Stephenson Jr. I am a board certified plastic surgeon here in Atlanta, and I've been practicing for nearly 20 years, believe it or not. And that time goes by fast, but as I mature in my practice, I wanted to kind of get my voice out a little bit more, and this platform allows me to do that. So, those of you who have joined me in the past, thank you so much. And those of you who are new, welcome, welcome, welcome. If you like this content, whether you're new or you are an old timer, so to speak, please share, please like. It would really help me. I would like to get a bunch of guests on here. I just don't want to sit here and talk. I can. It probably gets boring, but I like to bring other people in, get other perspectives. It really will broaden the channel, allow us to do some things, and really, most importantly, bring you information that you're not getting and you need to know. So, on that note, today I wanted to jump back in and talk about something that maybe have never heard of, uh, not something that's readily talked about. We always talk about potential problems with plastic surgery, and the usual things come up: infection, bleeding, bruising, swelling, uh, wounds, so on and so forth. But I wanted to kind of hone that down for possible, difficult outcomes in relation or related to breast augmentation. Breast augmentation is one of the most popular plastic surgery procedures. It has been probably since I've been practicing. Now, breast implants certainly get a hard knock, and to some point, deservedly so. But they are very safe. There are some issues with some clients, and you need to address those clients individually. But overall, breast augmentation is a very, very safe procedure. It provides a lot of satisfied clients. And with breast augmentation, even though it goes seamlessly, there are complications, which I've mentioned to you before, kind of the garden variety things, which happen very rarely. But there are a couple of complications that I want to touch on today. And they are, let me say this, they have to really mostly do with the displacement or abnormal position of the implant. So the first one is bottoming out. And that is where the implant kind of sits below what we consider the natural breast. And we're going to talk about what that is, illustrate that. And I'm going to give you my take on how to correct that. So that's number one. We're going to talk about bottoming out of the implant. Number two, we're going to talk about lateral or outward displacement. When women lay down, most women want their breast to kind of stay centrally, but just about all breasts kind of go out to the side to some degree. That's natural, but we don't really want the breast kind of migrating toward the armpit. So lateral displacement certainly is a problem, and we're going to talk about that, and I'm going to give you my take on how to best correct that. The third thing we're going to talk about uh, Symmastia, which is the uniboob, which is basically a fancy word saying that you have one breast that kind of comes or meets in the middle. And that's a really difficult complication, but it is correctable. And again, I'm going to give you my take on how to really prevent that. And then if it is something that does occur, then how we would fix that. And then lastly, we're going to talk about two other things. We're going to talk about affectionately something called the double bubble, where you have a breast implant and then you have a crease that looks really weird, and then you got the rest of the implant, and that's a double bubble. And we're going to talk about that. And then lastly, but most affectionately, we're going to talk about the Snoopy Dog Deformity. Yes, Snoopy, like in Charles Schultz in the Peanut. So we're going to talk about all those things. I don't know if you have heard of any of those potential complications. And so that's one of the reasons why I wanted to talk about them and bring this to your attention, especially if you are someone who's considering a breast augmentation. So, having said that, a breast augmentation just simply is a surgical procedure performed by board certified plastic surgeons where we enhance, augment, uh, give more size, more volume to a woman's breast that typically has very little breast tissue, and that her breast is out of proportion with the rest of her body. So we're in the business of creating nice proportions. We're not in the business of creating the ridiculous, where we have these huge boobs. I think people always get in their mind that they're gonna have these boobs that just kind of slosh around and make you look super, super top heavy. That's really not our motive at all. We want to make sure that you have proportion. So we want to make sure that when we have a client like this client of mine, an old client, comes in, she is small. Obviously, she is not proportionate with the rest of her body, and this makes her self conscious. And so she has a little bit of a discrepancy between her right and left breast. As you can see, very mild, a little difference in the amounts of breast tissue between the two, and a little bit higher crease on one side versus the other. But what we want to do in this situation, we want to make sure that we get safe outcomes, and we want to make sure that we educate, or certainly want to make sure that I educate my clients, and so that we can get a result that is seamless, such as this. This is what everyone wants. Everyone wants a nice, full, healthy, sexy, proportionate breast augmentation. And this is what people often get, but there are potential pitfalls with breast augmentation. And I mentioned those earlier, and let's dive deeper into those. So, the first one I talked about, I believe, is bottoming out of an implant. So, what's that really mean? So, let me bring up an illustration. So, we have an illustration where an implant is placed in a pocket, either on top of the muscle or beneath the muscle. And that implant over time kind of gets caught by gravity and descends. And as you can see in the illustration A, the nipples kind of lined up with the center of the implant. The implant's kind of centered on the chest, and the bottom half of the breast has a nice round shape. There's equal amounts, more or less, of breast tissue above the dotted line and below the dotted line for the most part. When you look at illustration B, where the implant has kind of dropped below what we consider the center of the chest, it does a couple of things. It elevates and makes the nipple kind of a sunrise nipple. It peaks up over bras, tube tops, etc. And so it elevates the nipple. It also creates greater fullness of the bottom half of the breast. So you have more tissue that's below the dotted line than you have above the dotted line. So at the end of the day, no one likes that. So how can we prevent that from happening? And with most of these potential complications, an ounce of prevention is worth a pound of cure for sure. So first and foremost, as the plastic surgeon, I'm evaluating the thickness, the resiliency of your breast tissue. If you have really thin, weak tissue, then we can't put a really large implant in, or we may need to add some type of breast lift to tighten the tissue to kind of help reinforce and give us a tighter breast so that we can put an implant in that will stay in its place over time. Second of all, we have to kind of dampen down the expectations and desires of our clients. Sometimes our clients come in and they're, of average frame, and they want implants that are 600, 700 cc's. And that implant is huge and it's heavy. And implants over time will, because of their weight, stretch out the skin of the breast. And if you get a real heavy implant, then it's going to stretch out that skin and it's going to make it bottom heavy. So, as the plastic surgeon and expert in the room, you say to the client, I understand your desire for fullness and shape. I believe going to a size that is above what I believe is recommended for your body shape, your contours, and what I call the footprint or the natural placement of space allotted for your breast implant, then we're pushing the envelope of having problems such as bottoming out. So you try to get them back to a point where they can have fullness, they can have shape, they can have an enlargement, but they can do that safely and that the result is, you know, somewhat timeless. It can last for a great duration of time. So bottoming out is certainly something that you can have occur. So prevention is key. But what if that kind of gets blown through, or maybe this client saw someone else and now ends up in your office or ends up in my office? So what do we do? The cat's out of the bag, so to speak. Well, then we have to kind of go back in and do a couple of things. We need a reoperation, so there's no non-surgical treatment for this other than wearing a bra that kind of reshapes the breast. I mean, that could be a non-surgical treatment if you want to consider that so. But surgery is the best option for a long-term result. So what we can do under general anesthetic is to go back through the incision, which is typically in the crease. If it is not in the crease and this implant was placed through the nipple, then we have to create a crease incision. That gives me the best access and allows me to do the most work. So through that crease incision, I'm able to do a couple of things. I'm able to remove that implant if I believe certainly the implant is too heavy and we're going to replace that. That's number one. Number two, that implant gets surrounded, and all implants do, by kind of a rind or a capsule that is really soft, like tissue paper. So I may need to tighten or make that capsule smaller, especially at the bottom, so that when we put in an implant that is smaller, it will fit that smaller size of that capsule or the space. So that's another thing I can do. Secondly, I may need to take off a crescent piece of tissue at the bottom of the breast where it's bottom heavy, so that if we go back to the illustration, the distance from the top of the dotted line or the point of the nipple down toward the crease has increased in illustration B. So I may have to decrease that distance by shortening it. And by shortening it, that kind of puts the level more nipple and it looks more like illustration A. So there are several things that I may need to do. I may need to do just one of them. I may need to do all of them. I may even need to reinforce all of that with a special mesh that I will talk about toward the end to kind of help support that, like an extra scaffolding or support like a internal brassiere or bra. I think people have heard of that. So those are some measures that we can do or I can provide to help bottoming out of a breast implant. But again, prevention is the key. So that's bottoming out of a breast implant. Just talked about that. So the next thing we're going to talk about is lateral displacement of an implant. So what's that really mean? I'll pop an illustration up here. Laterally displaced implant. So as I mentioned before with the bottomed out implant, we want that implant to kind of sit in the center of the chest. That implant's like a circle. We want it to sit symmetrically or evenly in the center of the chest or breast. Over time, that implant, because of weight and because of movement, natural movement, that implant can be pushed and stretch that pocket and stretch it out toward the side where that implant is basically heading toward the outer breast or armpit. And again, that's not really cosmetically pleasing. Sometimes muscle activity can enhance that, in my opinion. If the implant was placed underneath the muscle and the muscle in in my opinion always has to be weakened to a degree so that it can accommodate the implant and that the muscle does not kind of force the implant to into peculiar shapes and into peculiar places such as out toward the armpit. So again, surgical technique is key here. So that's prevention. Again, an implant that will fit the footprint, the natural anatomy of the breast, nothing that's too large or too heavy that can displace or stretch the tissues or skin out toward the armpit or even at the bottom. is a way to prevent this. So, an ounce of prevention one time, again, is worth a pound of cure. But again, if a client comes in and they're not mine, or maybe they are mine, and they come back and we have lateral displacement, how do we fix that? Once again, there are really no non surgical remedies other than a better bra. But women are going to get tired of that and they want to have something more permanent. And a more permanent solution resides in surgery, as we know. And so, under general anesthetic, again, I would go in a crease incision, and then I would not necessarily replace the implant if I felt that it was a reasonable implant. I would tighten that pocket again, that capsule out toward the side. I would kind of sew it so that it's tighter. It's almost like lacing up shoestrings. You tighten it up with stitches. That will help reduce the size of the pocket, reduce the ability for that implant to kind of go out toward the on point pit. And then I would reinforce it with this mesh that I mentioned earlier that we will talk about in detail toward the end, out toward the outside. Kind of again a hammock, additional support that will allow that area to kind of maintain its shape and closed off so that that implant stays more centrally. So lateral displacement of an implant is something that definitely can happen, but there are remedies before surgery even happens. And fortunately, even after the surgery has occurred and the result has been with you for some while. So that's number two, lateral displacement. Number three, we're going to talk about the uniboob. We're going to talk about Symmastia. And the uniboob or Symmastia is never something anybody wants to have. It is really difficult to correct. And this is a series of illustrations if the client were lying down and you're looking at them this way, kind of from bottom up. Illustration A shows natural breast, muscle is the pink little line or tube, breast tissue is yellow, the nipple is pink. You can see in the B illustration that the implants are placed below the muscle. And then C and D illustrate symastia. It can occur with one implant on one side or both implants. And symastia is basically where the implants come and either touch or communicate in the center. Your breastbone is a natural dividing point for your breast. If you were to look at your mirror, look at your breast in a mirror, whether you have implants or don't have implants, you'll see a little takeoff of your natural breast here at the bottom. Don't know if you can see my hand, a natural where the crease starts, and that's the natural takeoff. The crease is not at the center of your chest, and it doesn't meet the other crease in most individuals. So we want to naturally preserve that boundary as a plastic surgeon. Novices, either a novice plastic surgeon, which can occur, or someone who's not trained, may not have a strong appreciation of that boundary. And you've got to have a healthy respect for that boundary because it's difficult to recreate if it is breached. It can be, but it's just tough for everybody, for doctor, patient, loved ones, everyone. It is just tough. And the result is, in my opinion, always somewhat less than the result would have been if that area or that boundary was not breached. So again, illustration C shows where the implant on the left hand side of the screen has crossed that boundary, or the surgeon has erroneously or technically crossed that boundary, and that implant now is over the breastbone, and it gives fullness toward the center of the breast that is unnatural. And then illustration D is just it's a doubling down, if we can use that term, where both implants have been, basically over the breastbone because that boundary has been breached. In times past, historically, I remember this being a huge topic, and it still is a big topic where the tricks were you would liposuction the middle You would go back in and you would kind of take that again, that capsule, because the body forms a capsule, even though that boundary's been breached, and you divide that capsule and you sew it together so that you create space. So you close off the breast spaces and make them individual again with stitches. Again, the shoelace type of analogy for each breast so that you recreate that space. And then you would put big honking, as I used to say, stitches in the breastbone through the skin, catch the breastbone, sounds hideous, and then come out through the skin so that you can really get that skin to sink down. And like I say, you can probably liposuction before that if you wanted to kind of help remove any fat and maybe irritate the collagen layer underneath the skin to get that tissue to stick down to the breastbone so that we can create an obvious stopping point for each breast. Those techniques had moderate success, slightly greater than 50% in my experience and opinion. Now we have, again, the synthetic mesh. This mesh, it's not really synthetic. We have a mesh that is an animal mesh. And again, I will talk about that in the end. That helps recreate this boundary. This mesh is really strong. And if it's properly placed to recreate that natural boundary, then those implants will be centered. They won't breach or cross the midline or the breastbone, and it will look more natural. And so you don't have to liposuction. You don't have to put big honking stitches in the middle of the breastbone and skin. Just internally, you can close off the capsule. You can add this layer of reinforcement in as far as this natural animal mesh to kind of help recreate the boundary and the smaller space. You can change the implants out if you like, different size, same size. You certainly can do that as well if that is required. So the uniboob can be treated for sure. It's tough. So prevention really, really is the holy grail. So that's the third thing. So the next complication or potential complication that I want to talk about is, and I'm going to take a drink here because I'm thirsty and I'm going a little fast. So I'm going to slow down for a second. We're going to talk about the double bubble, toil and trouble. So, double bubble illustration is here. You have an implant in this illustration that's placed, whether it's a crease incision or in the nipple. The implant's below the muscle, but it's below the natural crease. So the natural crease still is seen, and the implant is placed below that to form a new crease. So you have breast tissue, natural crease, implant, new crease. So it looks like two balloons or a double bubble. It it is readily seen at surgery. Sometimes it's missed beforehand in evaluation. And it takes experience, in my opinion, to kind of know which patient could be set up for that. So, which patients are set up for that? In my experience, it's a patient who's a smaller patient with a really small, tight breast and a really short breast, meaning the distance between the nipple and the crease is really short. Let me give you an example. If a client came in my office and needed a breast augmentation, the distance between the nipple and the natural crease may be 5, 6 centimeters. In someone who may be set up for the double bubble deformity, that crease nipple to crease distance may be 4. That's a tight crease. And so when you go in to place the implant, to place an implant of any reasonable size, you have to expand the footprint a bit. And there are a lot of plastic surgeons would push back and say you should never expand the footprint. The footprint is the footprint and you need to work within it. Some clients I think reasonably want a fuller breast that's proportionate. And to achieve that, that distance between the nipple and the crease needs to be longer so that you can get more volume. But you have to beware as the plastic surgeon, and this is where training and experience comes into play. When the client is sitting in front of you and they're 5'2", 110, they've got an A cup breast with a really short nipple to crease distance, and it's tight as a firm breast. And they want, a fuller, C cup per se. And you want to put in, based on your measurements, experience, patient's expectations, and desires, a 300 cc implant. Then that implant is going to be bigger than the footprint. So your crease is going to get lowered so that you can have room for that implant. And so that natural crease is tight, and it may show up between the nipple and the new crease. And that's not a good feeling in surgery. Let me tell you. I don't present myself as holier than thou, that I've never had any issues that I had to work through with clients. I've worked through them successfully. I think my track record speaks for itself, but you can ask my clients in surgery, when you place that implant, or when I placed that implant and I didn't, as a younger surgeon specifically, didn't recognize that, and I've got this line, it's not a great feeling. So what do you do? In surgery, what I try to do very carefully is I try to break up internally from the inside t- this kind of tethering of the old fold. I try to soften the skin from underneath so that it relaxes and has less of a stark appearance of a line. That works to some degree. If I had to put a percentage on it, it probably works to reduce the visibility of the line by 30%, 40%. And then you just have to tell the patient after surgery, or at the first, you know, follow-up visit, hey, we had a tight old crease. You can see the line. The implant may help us out by having weight. It will stretch out that lower half of your breast and help relax that tissue. So we just got to wait it out. We got to just wait it out and see how the body responds. Now, with that being said, a lot of times that tends to work out, and that old crease slowly resolves where it's not an issue due to stretching of the tissues, uh, due to the weight of the implant and healing. Occasionally, that does not. And so, what do you do? Well, you got a couple of options. You can reevaluate the size of your implant and sit down with your client and say, we thought the 300 would work well for you. It certainly would give you the desired breast size and volume that you wanted, but because of your anatomy, we it can't accommodate that. So we have to color within the lines. So we gotta use, a 250 cc implant so that we can then take that larger implant out, put the smaller implant in, maybe in the same space. Maybe we put it in the space above the muscle so that we can reattach the muscle at its natural attachment, which corresponds with the old crease, and we've solved the problem. Maybe we reinforce that again with mesh. Maybe we fat graft that as well underneath so that we can give that area some volume so it doesn't have an indentation. So those are some of the methods that you can use. Smaller implant, change in the location of the breast pocket, reattachment of the chest wall muscle, fat grafting beneath to give volume and lessen the sharp contour of the old crease, and then let time do its will or have its way. And usually that resolves it. But again, just like with the uniboob or Symmastia, you've got to be on the lookout for the tight, small breast and just inform your client. Hey, we've got a tight small breast, you want a little bit of a fuller implant. That requires us to lower the natural crease, and we may see some remnants of the old crease, and we'll try to take care of that during surgery. We'll give, you know, nature time to take care of that in the recovery period. But if it doesn't, then we may need to do or have additional procedures to soften that. And if you give that information on the front end, it's not an excuse on the back end, and that just comes with experience. So that is the double bubble, toil, and trouble. So we want to stay out of trouble for sure. Lastly, as far as complications that you are uncommon that you may not have heard of, is our friendly Snoopy Dog deformity. Not Snoop Dogg. It's Snoopy Dog. It's Charles Schultz. It's not Compton. It's not the CPT. And here we go. It's the Snoopy Dog deformity because the breast looks sad, like our good pal Snoopy. And this can occur, in my opinion, in two scenarios. And I could probably be challenged on that, but two major scenarios. You have a client that comes in who obviously needs a lift in addition to an implant. That client refuses to have any other incisions other than the breast augmentation incision. And she just wants a larger implant to fill up the empty space to quote lift the breast. You get about that much lift for being putting in a larger implant in a breast that's droopy. So let's just get that out of the way. It is not going to give you any significant lift, but sometimes plastic surgeons agree that with the patient that because the patient does not want to have a breast lift but needs a breast lift, but will have the augmentation, they'll plow ahead with the understanding from both sides that this is not the most optimum of treatments and outcomes. So when that happens, then you end up with this. And now it's up to the patient, in my opinion, especially if you told the client, the patient, before surgery, you needed a breast lift. And this has actually happened to me. I've had a client just beg me. I had many consultations, two or three consultations. You need a lift. You need a lift. Oh, I'm so afraid of the scarring. I'm so afraid of the scar. I just want full breast. I just want fuller breast. And we did this, and she had a Snoopy Dog looking breast. And then she was like, "Well, I really wanted them to be more up." Well, that required a breast lift in addition to the implant. And so now she's going to end up paying for another operation, another anesthetic, and she's going to have another recovery period, which she could have just had one. So the preventative method here is two. One's on the client and one's on the doctor. Truth be told, to the client, you need a breast lift. That's what needs to be done so that you can have the best outcome from your operation, so that you have a fuller, shapelier, well positioned breast. On the other end, the doctor, hey, you need a breast lift. I am not performing just a breast augmentation without the breast lift because that's not the optimum treatment. I'm sorry that you are a little bit hesitant. I'll try to give you more information, explain better, refer you to other doctors or other resources. But until if you ever wrap your mind around that you need a lift with that and you want to work with me, then that's what we'll do. So there's your preventative measure right there. So that's scenario one. Scenario two is that, hey, you were smart at the doctor. The patient was cool. The client was cool. And like, yes, we want a breast lift with the breast augmentation. We're going to do that. And I'm going to really say this is a novice surgeon, a new surgeon who's really kind of getting his or her feet underneath them. Or it can always be someone who just doesn't understand and has not been properly trained, but positions themselves, as a plastic surgeon and posture syndrome. And they do a breast augmentation or perform a breast augmentation and they perform a lift, but they're not, I wouldn't say aggressive, they do an inadequate lift. And over time, It looks good initially because it's swollen and tight, but as the swelling goes down, there's not been enough tissue taken out and tightened and lifted from the breast, and the breast droops off the surface of the implant. And now the nipple's pointing down again. That is a technical error from the surgeon, more or less. There can be some other factors to contribute, but more or less, if there wasn't an appropriately performed breast lift, then that can really contribute significantly to a Snoopy dog breast. So, be that as it may, whether this was someone that never got a breast lift with a breast augmentation performed, or someone who had a breast augmentation performed, but the lift, was inadequate or failed, for lack of a better term, what can you do? In my opinion, you can simply do a breast lift, an adequate, meaningful, impactful breast lift right over the implant. You don't have to disturb the implant, especially if there are no problems with it, especially if the patient or client doesn't request that anything is done to or for the implant. So that's a solution that's readily available. But again, as with really all the illustrations, an ounce of prevention. So that's a Snoopy Dog Deformity. So we want to avoid that. So, in summary, and we'll work a little bit backwards here. We talked about the Snoopy Dog Deformity. We talked about the double bubble, where you have two creases and it looks like you have two implants. We talked about Symmastia, which is one boob of the uniboob, where the natural, strong boundary of the breastbone is violated and the implants kind of meet in the middle, or one implant goes over to the other side to visit the other breast implant. So we want to avoid that. That's Symmastia of the uniboob. We talk about displacement or lateral drift, or drift out toward the armpit of the implant. And then lastly, we talked about the implant just settling too much and bottoming out and having a bottom heavy breast. All these are correctable. Again, preventative measures are great and will save a lot of issues. But if they weren't employed, couldn't be employed, and now we have these issues are correctable. The uniboob, the lateral displacement, the bottoming out can be treated with the techniques that I mentioned before, but I mentioned a mesh, and I kept kind of being a little bit elusive to that. There are several meshes. There's synthetic meshes and there are natural meshes. I'll put it that way. And it's really surgeons' preference of what they like and what works well in their hands. In my hands, I particularly like a proprietary mesh called Stratus. It is basically collagen. Collagen is the layer that's just below the skin. So the skin is removed, and you have that thick, whitish layer that's resilient. So it's collagen. Medical term is dermal. So all the cells from that dermis are removed because the collagen is from a pig. Believe it or not, whether you like it or not, you can push back. We have some similarities in our immune system and genetics that pig skin can be tolerated and accepted by us if implanted. So that pig skin or collagen from the pig minus the skin is used, and the cells that are in that collagen or dermis are removed by a proprietary process so that it will not render any type of rejection response. And again, that is called stratus. And it kind of looks like this. Okay. You're going to get it in different sizes. It's typically for breast implant malpositions or abnormal positions, sometimes breast reconstruction, and sometimes it's used in the abdomen for hernia repairs or large hernia repairs. But it's really strong. and it's really unforgiving. And that's a good thing because when you place it and map out your surgery and you want to reestablish a boundary, let's say for the uniboob, you want to place it right where it needs to be and you want it to stay because you want that implant never to go past that boundary. So it's unforgiving for a reason. And I really like it. And it's been well tolerated when I've had to use it in my clients. No issues. The body kind of takes care of it, melts it away and replaces it with its own collagen or integrates its own collagen into it and reinforces it. So it's really, really, really a helpful and useful product. And it's called Stratus. That's Strattics. Really good mesh. I really like it quite a bit. You can use it in lateral displacement and bottoming out. And this is just an illustration. It's an illustration more for lateral displacement, but you can see you can add a component to support the bottoming out, where it's more of like a hammock or support or internal bra, like I mentioned before. Generically or generally, these types of meshes that are either from pig, human, and sometimes cow are called acellular dermal matrices, meaning all the cells have been taken out, so there's no strong immune response, no rejection reaction or potential, or less of a rejection reaction potential. And they're used to support and allow ingrowth of the natural collagen from the client or patient to reinforce and sometimes replace that mesh to help reinforce and resecure that boundary. So that's how you would use Stratus for lateral displacement and even bottoming out. I think in bottoming out, it really needs to even be placed more toward the center, almost like a internal bra that's more like a cup that kind of holds the breast up like that. In lateral, it can be more out toward the side, more like a hammock. So those are you can position it in different ways to achieve your effect and goal. For Symmastia or the uniboob, it's placed just where you think. It's placed toward the middle. It's secured to the boundary on the breastbone and then secured to either the muscle or the remaining capsule to wall off that space close to or over the breastbone. So that's how you use that mesh, and it's super helpful. It's super expensive too, really expensive, and that adds to the cost, especially if you already had a breast augmentation and you have these, I would say, unusual complications. It's going to cost you anyway to get it revised. It's going to cost you a surgeon's fee typically, if especially if it's done by another surgeon. If it's done by the same surgeon, that surgeon may choose not to charge you a surgeon fee, but you're still going to more likely have an anesthesia fee, a facility fee, and you have to pay for, your prescriptions, and you have to take time off work, so there's loss of income. But if these particularly three complications occur: Symmastia, lateral displacement, bottoming out, it may require that mesh, that stratus, which adds to the cost, and it's pretty expensive. It's about $4,000 for just that mesh. It's usually two pieces. So you get two pieces. You just don't get, it's not $4,000 per breast, but still it's $4,000, and that's nothing to sneeze at. So the reason I tell you all of this is so that you are armed with information. If you're interested in a breast augmentation and you go and you chat with a surgeon and they tell you about the pros, the cons, and they ask you if you have any questions, then you can ask them about some of these things. Have you ever had bottoming out? What do you do for it? Is it preventable? Have you ever had Symmastia? Do I have a chance of having a double bubble? This is why I present the information so that you can have it, so that you can go and get the answers you need, choose the surgeons that you feel most comfortable with, and have your surgery if that's what you want to do. You may go get all those answers like a particular surgeon, but choose to say, no, I'm not in a space where I want to risk that. Hey, that do you. But the point being is you have information. And I just don't think a lot of surgeons, a lot of forums on Facebook and other platforms talk about these particular complications. It's the usual things: capsular contracture, implant, leakage or deflation or rupture, but nobody really talks about these. And they are possible, albeit rare, but they're possible. So it's good information for you to have. So again, really wanted to make sure that you had this information. You want to start here and you want to end here for sure, and nothing really else in between but that surgery, that recovery. So if you have really liked what you've heard here, I encourage you to watch my other podcasts. If you're listening on podcast platforms, I encourage you to listen to my other podcasts, and I encourage you to jump on the YouTube so you can actually see some of these illustrations and you can see my lovely face if you think it's lovely, and it'll put context to the audio text. And I would really, really, really appreciate it if you would subscribe to the YouTube channel. It really would help me grow the channel, as I mentioned before. Uh, if you don't even subscribe, share it. Share it to somebody who you think make use of the information. Somebody you've talked to who's talked to you about breast augmentation or this dissatisfaction with their breast size and shape. This might be some helpful information for to move them forward in whatever direction uh, life is going to take them to make that decision. So once again, I appreciate your time. It's always a pleasure to come and bring you this information. I enjoy it. I hope you enjoy it. And until next Saturday, we will see you. Please be safe wherever you are in the world. Peace.